have the pleasure of introducing our guest speakers today. Our first speaker is Dr. Rosario Trifiletti, who we know as Dr. T. I kept saying, they'd say Dr. T. I'd say, who's Dr. T? So Dr. T is from New Jersey, and Dr. T is a champion for many of you. He has offered both personal and long-distance support. He has been very intensively looking at many markers to try and sort through what biomarkers might be acknowledged and identifiable in our clients and patients and family members. Part of the stimulus for this conference was that Dr. Trifiletti happened to be in Boston for a weekend last spring, and Kim Panton located that he was here and asked him would he kindly come down and speak to some parents who were struggling with PANDAS. And I believe it was a Wednesday or Thursday morning he agreed and drove down to our small town south of Boston. And in 3 days' time, we had 125 parents show up for his talk. The room was packed. We actually didn't even have enough space. And it was that, I think, evening that really gave the stimulus to our parents here to have the committee go further, to make a committee and go further with a conference. So we're great happiness. We're going to welcome Dr. Rosario Trifiletti.
Glad Peggy took the time to say that because I was going to say it or she didn't. And I really want to thank Kim. Kim Panton is really behind all of this. And it's her hard efforts. And if it wasn't for her, we wouldn't be here right now, that's for sure. And, what I want to talk about today is a very personal view of this disease called PANDAS, which I've been thinking about for a very long time, and this all started with me. I don't know how many of you are Roman Catholic out there, but or Catholic in general, or even if you're not, you probably know the story of Paul at Damascus, who was suddenly smitten and became blind, and underwent a religious conversion. He was actually called Saul at the time, and he changed his name to Paul. It was a religious conversion, and something like that happened to me. At a talk I attended, I think it was either 1997 or 1998. It was given by John Zabriskie at Cornell, where I was at the time. And I first heard this disease called PANDAS. I was a neurologist. I never had even heard of it before because sort of child neurologists and child psychiatrists have their own little worlds. And after that, I was so interested in it. I had an interest in Tourette's syndrome and movement disorders before that, and Sydenham's chorea in general, but it really became the focus of what I did, and I completely changed my research focus at that time, and I was working on nitric oxide at a completely different area, and then began to work on this, and probably at the cost of my career to do that. I had to leave Cornell, eventually go to St. Vincent's and UMDNJ, and then sort of found my way to private practice because nobody really wanted to hear at that time in an academic setting about this disease I was obsessed with. So, now this is the typical story we hear. A frequent complaint heard from the mother is that the character of her child is completely changed. We hear this over and over again. It's, I've heard this now many times. The hallmark of PANDAS, I wouldn't call it quite a sine qua non, but it's very important, is the rapidity of change. And if you've been through this, I know many of you have, this is terrifying. I mean, to find one child going to bed and then this monster, this different child waking up that you don't recognize anymore. And I know parents think of the same things, abuse or some sort of intoxication, etc. But once those things are rapidly ruled out, you're left with this child that's undergone a mental status change, basically. That's the best way you could describe it. And the following are the most striking of the mental changes. The patient may do these odd and meaningless acts, by which we call OCD. There's a disturbance of the moral sense manifests frequently in a strange perverseness, a great irritability of temper with emotional outbreaks, which we would call emotional lability, disturbances in the faculty of memory and attention, transient loss of the power to read and write may exist, and acute melancholia may occur. And in rare instances, the impairment of intellect may be progressive and terminate in dementia and hallucinations by day and intervals between sleeping and waking. Now that sounds like something that you might find in a review article today. However, the slide was actually written, those came from 1894, William Osler, amazingly described that. PANDAS is in that book. I mean, obviously it's not called that, and it's buried in this book on Sydenham's chorea and choreiform affections that he wrote, which became a very important and standard book in the field and influenced many doctors. So one of the important things in the history of PANDAS that you couldn't have predicted at the time is the tremendous influence Sir William Osler had. I mean, he was, I wouldn't want to say Dr. Oz, because he was a little bit more sophisticated than that, I would say. But although I like Dr. Oz. It's a friend of mine. But he had tremendous influence in medicine. Many things are named after him. And what he said in that book got remembered and passed on to other doctors. Another thing he mentions in this book, and he uses terminology like chorea major, chorea minor, and chorea insaniens, which we don't use anymore. They refer to different things. So you have to dig a little bit to see what he's talking about. But he uses this term chorea minor, and he mentions the association between arthritis and chorea did not escape the physicians of the last century. And when he says last century, he means the 19th century. So they were well aware of this relationship between arthritis and chorea. But he realized that the disease may develop acutely in the course of acute rheumatic fever, for which he noted a very strong association, special association, but also gonorrhea, secondary syphilis, postpartum fever, multiple suppurative polyarthritis, which is various etiologies of infections, diphtheria, measles, typhoid fever, which of course we don't see much anymore, and scarlet fever. And he says here, with the exception of rheumatic fever and certain forms of septicemia, there is no very intimate relationship between chorea and the infective disorders. So he's basically telling you, from his observations, that this chorea is associated with this condition that we know now is related to streptococcus, but also has other causes as well, which is pretty much what we believe right now. So the guiding principles of my practice that, I think most of you know that I'm in private practice in New Jersey, and I'm, pretty much a PANDAS-focused practice, trying to really understand this disease from my background, is number one, no child left behind. And we try to treat almost everybody we can. I mean, we keep our prices as low as we can, and I can't accept insurance because I couldn't. I tried to, but it was just impossible. I would have been out of business in 3 months. So I thought it was more important that I stay in business. But also, if we do have children that really financially need it, we'll get it done. I mean, so I really feel that's very important. I try to learn one new thing every day, and try to learn something from every patient. That was drilled into my head in medical school, that you see a patient, you learn from the patient, you read about the disease the patient has, and that really reinforces it in your head. We try to do as much good as we can, and really nothing is off the table. I'm not worried about, if I have to give SSRIs, we give SSRIs. Whatever we need to do to cure the patient, that's most important. But while first doing no harm, that's very important too. There's a lot of treatments in PANDAS, as you've heard already, that are potentially dangerous. We try to be as patient-friendly as possible. So it's very hard. We're very busy, so sometimes we can't answer emails and phone calls as fast as we'd like. But there's many people that I know have called, and I picked up the phone myself personally. So there's none of that stuff where we try to schedule people quickly because I know that a lot of people are in crisis. I know the nature of this disease is somebody tells you, I can see it 6 months from now, that's worthless. I mean, that's not going to help you, And we try to have no boxes. And there's the emperor has no clothes, so I don't believe in anything other than the truth. So we try to get to the answers. So our goal is to understand the disease and leverage that understanding to the benefit of the patient. how do I do this on a shoestring budget? I'm out of academia now. I'm personally not doing well financially, and I have no grants. So, so we're really kind of in trouble. So how do we do this? We take advantage of a lot of things. Stand on the shoulder of giants. That's Newton's term, right? I mean, use those people that have gone before. Osler's one of them, but Dr. Suedo's another, I guess. I mean, her work, Dr. Cunningham, and all the people you've heard of yesterday, there are a number of giants there in the field that have taught us a lot about the disease. So, you know, use that information. Learn something from every patient, an analogy. How have I seen this before? There's a lot of weird things in PANDAS. You know, you get some kids that are, you know, what is this? You know, some strange compulsion or something, or some strange behavior. Have I seen this before? What worked in patient 1 that we can apply to patient 2, that type of stuff. And of course, as we get genetic information, which I'll talk about towards the end of the talk here, we can then start grouping patients not only in these clinical groups, but also into genetic susceptibility groups. It's very important from what I'm doing, because I have really only clinical research I can do. I don't have a lab anymore. To see a lot of patients, that's really important, I think, because it's only with large numbers that things reach instant statistical significance, and you don't have to worry about what your data looks like. Is it one distribution or another? If you have 2,000 of anything, the data will talk to you instead of the other way around. You don't have to look at it, because it'll draw its own distribution curve, and you can figure things out. So gather a lot of data on those patients and do exploratory data analysis, which means just look at the stuff. What do we have there? And then formulate guesses that can be experimentally invalidated. In other words, the key to science is to have something that you can prove wrong. I mean, otherwise it's not a scientific proposition. Like God exists, many people believe that, but it's not scientific, because nobody can disprove it. Although I think they can't prove it. I mean, you know, I don't want to get into that. I'm sorry. But nevertheless, I mean, we try to say things. We can't just say there's a chemical imbalance in the brain. That's true, but nobody, you know, it's not scientific. We have to say there's a high level of histamine in this nucleus of the brain at this time in this patient, and then we can test if I'm wrong or right. And of course, that's the only important thing, is experiment and say. So we're trying to basically sit on the cutting edge of things, try to get hypotheses together by looking at a lot of patients to try to understand the limits of this disease. And you know, I have to say that the heroes here really are your children and their arms for phlebotomy, because we draw a lot of blood, and they're the real heroes. I feel so sorry that I probably have caused so many kids to cry for all this blood. Our goal really is to understand this disease as best as we can from the point of view of practical medicine, because this is the other value of this stuff. I love all the deep basic science. That's where I came from. But in the lowdown, if you're going to talk to your pediatrician, he's not going to understand about Th17 and any of that stuff, most likely. He might, you know, but most of the time they're not going to understand. They're going to understand basic, simple markers that they can use and are familiar with. So if we can put it in that term, that would help. And our goal is to leverage your understanding to the benefit of the patient. So what are the symptoms we're dealing with? This is just very quick, just in case people weren't here. The original definition of PANDAS. I'm going to call them the Suedo criteria, because there are other criteria. I think that's fair enough to call them that at this point, but I know I've emailed Dr. Suedo on that, and she's obviously too modest to agree to this. But nevertheless, we'll call it that. Onset of symptoms between age 3 and 11, acute onset, and this is very important, motor and vocal tics, because that comes out of later definitions, although, you know, as a neurologist, that's a lot of what we see. We get referrals a lot of times for that aspect of it, because Tourette syndrome and movement disorders have traditionally been thought of as a neurological disease, and or OCD. So in this definition, you even have to have OCD. You could have motor tics alone, and that would be okay too. And this was the early criteria. And the hardest one, I think everybody knows, that the bugaboo in all this stuff is to temporarily correlate that with a group A beta hemolytic strep infection. And optionally, they're helpful if they're present, the presence of choreiform signs. Typical patients. So what do you see? So you open your practice and patients walk in. A typical textbook case will walk in. 6-year-old, I think anybody here would make this diagnosis instantly. 6-year-old child diagnosed with a strep throat. These are real patients, you know, just simply cut the case down to a skeleton here to make it quick. diagnosed with a strep throat. Child is treated with antibiotic. One day, a few weeks by the pediatrician. A few weeks later, a sudden change with facial blinking and humming sounds, school phobia and avoidance, and separation anxiety with a renewed need to visit their parents in their bed at night and sleep problems. And this rapidly improves, it turns out, with ibuprofen in this patient as well, once this flare-up occurs. Then another type of child walks in, a 12-year-old child, a little bit out of the 3 to 11 criteria range, diagnosed with walking pneumonia, treated with antibiotics, a gradual steady change over the course of weeks, fear of vomiting or seeing other people vomit, decreased appetite, eventual anorexia, separation anxiety, need to visit parents in their bed at night, and sleep problems, again, rapidly improving with ibuprofen while we're waiting to draw the labs on the child. And then yet another variant, this is, maybe that one you'd say, okay, that sounds like PANDAS. Another child, 2-year-old child diagnosed with an asthma-like illness and an abrupt change over the course of weeks, a marked increase in motor restlessness. I mean, this is, obviously terrible twos, but terrible twos to the 10th power, basically. The child looks manic. I mean, literally jumping from table to table. I mean, just a sudden change in the motoric behavior of this child. So another way to I say this is like a 3-year-old you want to put on, you're seriously considering putting on Ritalin. I mean, so if that happens, this is what you have most likely. This child has an markedly increased sensitivity to sensory stimuli. That might even be what, some people think hyperactivity and motoric hyperactivity is due to the need to move. The same way you like to move when your feet go to sleep. You sort of like to walk around to make sure your feet are still there. That's the same thing, sensory sensitivity, repetitive ritualistic behavior. And then when you have all that in a young child at age 2, guess what? The diagnosis of PDD-NOS is considered. The only difference is if you catch it now and you're aware of it, it rapidly improves with ibuprofen. I've seen over the course of years in neurology, I've seen quite a few kids like this that I think back, and I remember a number of them undergoing autistic regression, language loss, and what the heck is going on? Was late onset, or it was probably PANDAS. I missed it, in that poor child. But well, the whole point is that after you think about this hard, you realize these 3 children have the same disease process. Okay, so when you deal with a new disease, I mean, you always have the same problem. It's called the lumpers versus splitters. Okay, are we going to split this disease off? Are we going to be very narrow in our definition? That's great. I mean, that's wonderful, and that's very important for research studies. I mean, so we know exactly, that's why people do experiments on white rats that are inbred, because we eliminate a lot of variables. So the more narrow and exact we make our criteria, that's great for research studies. But we got to take care of real people. We don't want to leave any of those kids out, any one of those 3. So we also have to have a broad enough net to catch them, And we're not worried right now, if they fit a criteria or not, what name we give it. We just want to get the kid better, and by understanding them. So what is this PANDAS thing? Does it even exist? That's question number 1. And I think by now we're pretty sure. We wouldn't be here, right? I wouldn't be doing what I'm doing, So it's almost like if something doesn't exist, most people don't study things that don't exist. So those people that don't believe it exists are not studying it, really. So it's almost like it doesn't make a lot of sense. So then if it does, and I think we've heard that, it does exist by, Dr. Suedo had a beautiful talk yesterday. It was very convincing to me. That she had to convince me, but I mean, I was on her side all the way. But if it exists, what are its limits? That's very important. What's the limits of a disease? When does PANDAS end? What is not PANDAS? How do you know that? I mean, you see a lot of kids and you say, oh, I've never seen, one thing I can tell you, seizures, okay, which, child neurologists deal with a lot. We know they're present in 0.5 to 1% of the population of people have epilepsy. So if you see 2,000 kids, you're going to see 5 to 10 kids in there by chance that have epilepsy. Then you say to yourself, and I'm seeing 20, that number sounds about right to what I'm seeing, So I don't think that's necessarily part of it. So if a kid comes into you with seizures as a big part of their presentation, that automatically raises a red flag, And other things like that. All of a sudden you see things like Ehlers-Danlos type 3 start becoming too many patients with that I'm seeing. There's something wrong with that. And so that's how you develop disease associations and start seeing that. But you have to know what the limits are, when it stops being PANDAS. And as I said, you know, as I mentioned, the way to define it. And, you know, we were all, everybody that worked in this field hit this thing called the mid-2000s, I think, the mid-2000s controversy. And this is typical stuff. I think this was alluded to yesterday, but these are the papers. You know, whenever you see a paper with a question mark in it, it's always the second proposition, you know. So the guy's losing its, the guy's always, it's always a negative paper. I've never seen one yet. I mean, and when people write too many negative papers, that raises a red flag to me. So I won't, you know, you could read too, so you can see the name up here. I won't say who it is. But I think people know it. The Antichrist of PANDAS, I call this guy. How about that? I hope he's not in the audience. But, yeah, he's really out to get it. But, so this was a panda sighting in 2005, according to, is it a zebra or a horse? So we don't really know. It's not really, it doesn't look like a bear anymore. So, so then they wrote this paper. I mean, this is not, I mean, these are people look, Harvey Singer's on this paper. He's somebody that if I wouldn't be here now, I know. I wouldn't be here right now if it wasn't for him, because he really trained me at Hopkins, and I know quite a few people on these papers personally, so there's nothing personal here. They were doing a study, and that was their interpretation of the study. This was a study in which, like so many in the literature, trying to correlate streptococcal infections with obsessive-compulsive symptoms, and these things, every single one of them can be criticized for either the number of patients, for how they define the strep infections, and what type of patients were they looking at. I think Dr. Who was it that dug up the actual patients that were on the in that group? I think it was Dr. Suedo that mentioned that, and some of them didn't even have what they said they had when they actually looked at the data. And it happens on these multi-authored papers that kind of things get lost in the soup. That's one advantage of doing things yourself. Now here we go with the next panda sighting. It's just a unicorn. This is just a mythical disease. There are problems with the strict PANDAS model, P-A-N-D-A-S. We know now it's not just a pediatric disease. The 3 to 11 is definitely too narrow. There are kids under 3 and a lot more kids over 11 that start with this disease. So we don't want to just tell clinicians 11, put that thing in their head, and so when a 13-year-old walks in, can't have PANDAS, you know, because Dr. Suedo said 11, and that's it. Yeah. So, you know, that's okay. I mean, you know, we want to define the disease, you know, for the purposes of research studies. If you want to take the purest sample you can, that's great, you know, so you can compare apples to apples, but we can't do that. So infants under 3, adolescent, and even adults. This is the hardest one. This one I'm least sure about. It's definitely the rarest one. Somebody suddenly at age 40 waking up and having PANDAS. So obvious thing, you know, you'd say to yourself is, maybe this person just had it when they were 4 and 5 and forgot about it, and, you know, it went away for a little while, and here it comes back again. We know this disease comes back. So you can never be sure. I think that's always going to be the odd group. Now, you know that Dr. Janicki, Michael Janicki, a major figure in, you know, in OCD in this country, has a great interest in adults with PANDAS as part of their OCD group from his work. So this is going to be studied, you know, because of that. And there'll probably be a lot of people. I've even heard story. I mean, you know, I heard a story of an 80-year-old person with a UTI who actually had severe OCD, was a strange, hoarding grandmother, and she got treated, got better. So I don't know if that ever goes away, this thing, you know, so who knows. Many other symptoms, though, besides OCD and tics, we know about that. It's not just strep. And here's one that I think may cause some controversy, but I believe it. The onset is not always acute. That bothers people a lot. Yeah, you know. Why could that be? I mean, okay. I mean, it doesn't meet the strict definition. But if there are people that can be helped by the same treatments and the same disease processes, then we can do it. Now, that could happen in 2 ways. Like, when did your kids, can you tell when a two-year-old wakes up and is a different person? It's pretty hard, you know? So it might have started then, and then the kid had chronic infection after infection after infection after infection. So the whole thing looks like a chronic process. The common denominator between all this stuff is inflammation. And the thing that I think is an important thing, and I think I see is important, the vast, almost a diagnostic and therapeutic test is ibuprofen. So that's, I think, helpful. And it needs to be studied. I might be wrong, but, you know, but that's definitely a test that should be done, is how well that works. First of all, it's easy to treat, and also helpful. Here's another thing that, just to point out, I think it was mentioned to some extent. In medical school, I got one lecture on Group A on gram-positive, I don't know, it was just on streptococcus in general, and maybe 10 minutes of that was Group A strep. So that's what most doctors know about Group A strep, is in that lecture, unless they go and become PEDS ID fellows, but they're not going to really learn a whole lot more. Definitely psychiatrists don't get lectures on Group A strep very often. So it's a tough area. I bought there's really one amazing book that's called Gram-Positive Pathogens by Vince Fischetti. It's a multi-authored text. Dr. Cunningham has chapters in it. But it's a beautiful book on this. And in that book, you can really see and there's maybe 300 pages on strep in there. You can really see what strep is all about. It's really complex. There are hundreds of virulence factors in strep. This is an organism that's been around for probably a billion years in that ballpark. So it's had and it divides every 40 minutes, okay? So that's a lot of evolution in there. You can do the math. It's incredible the possibilities that this thing has to evolve and deal with. So this thing is highly, highly sophisticated in dealing with our immune system. And that's true of every infectious pathogen. So that's just evolution and numbers, and the fact that these things are little and reproduce very quickly. So we know that there are strep carriers. These are intermittent, asymptomatic patients. Very important point, intermittently shed strep. How do I know this? There was literally a crazy mom of mine who happened to be a psychiatrist. The kid, she was able to do this test. She cultured her kid every day for a month and sent the sample off to the lab. Nobody would allow that in the protocol. But there you could see plus, minus, depending on where you hit, you got a positive or not. So I don't even use, some people would disagree with me. I'm sure they would disagree on this. I don't even use throat cultures because they're so inaccurate in terms of that. In fact, I use the blood instead because I think the immune system will see it if it's there, and it will see other places too. The throat, if you have anal strep, if you have strep in Peyer's patches, other places like that, the immune system will see it and should respond. The other problem is it doesn't always respond. There are low strep responders. About 10 to 20% of kids have positive throat cultures, sore throat, go into the doctor, get cultured positive, the ASO never rises, or rises very little, or never gets to that point where it reaches the cutoff. That throws a lot of clinicians off if they're using that stuff. And then also we know about extra pharyngitic sources like the gut and the anus. The anus, of course, we can evaluate that, but the gut we have, really is a silent area, which is very hard to see that. But people know from taking appendices out that there is, for example, strep in the appendix. That's a pretty well-known thing for a long time. So how do we deal with this crisis? Number one is Osler to the rescue when he mentioned all these different things. So just, for example, red is a strep infection. The blue is some non-strep infection. Each time the patient has an exacerbation on top, perfectly correlated. Just look at the reds and forget that the blues even exist. You get no correlation. So that's a problem. The problem here is that there was a pre-assumed pathogenesis of a disease that we knew nothing about. So that's a problem, in terms of that. More exploratory data analysis was needed before you could do these studies, really. So, as you know by now, this was parent-driven, amazing thing. I was so happy to be involved in this in 2010. Thanks to parents banging on the door of their government, which is a wonderful thing to see. They basically said, look, we have these kids, our doctors are just giving us the runaround here, and we can't get anywhere, and please help us. I think the problem is, they're just looking at these PANDAS criteria. Can you just change things around or just, meet our needs a little bit better? So I think that's a pretty fair way to say what that was about. But a redefinition of this syndrome that's more accurate. So one obvious thing, if you're going to do this, the thing that's bothering people is the strep. I can't find the strep, the kid doesn't have it. So take everything out. Forget about the strep. Forget about mycoplasma. Just describe the symptoms. It's a kid who was normal 1 minute, and then the next day is a different person. So that's the basic idea of PANS, and it also took into account other symptoms. So if you had some of those, and by now I think most of you know this just real quick, abrupt onset of obsessive compulsive disorder or severely restrictive food intake. It has to be abrupt, and it has to be an OCD. It has to be a psychiatric disorder, something we would normally put in psychiatry. OCD or severely restricted food intake. And I think, as Dr. Suedo noted, this was due to a couple people in the audience more than anything else. So this took it away from neurologists, which of course affected me a lot because I'm a neurologist, and the tics. So tics were de-emphasized in this part. Although it was definitely part, the Suedo criteria said acute onset of OCD and or tics, so it could be tics only. But that was taken away from PANDS. Instead, anxiety, emotional lability, irritability, aggression, behavioral changes, deterioration. I won't go through this. You know this list by now by heart. Your children may have many of these symptoms. And I can tell you, if this thing is dialed up to 10, if everything is on this list, this kid is going to look one of two things: either polydiagnosed, ADD, PD, alphabet soup child, multiple diagnoses, 5 different doctors, and you have a list. You say, how can my kid have 5 different things? This is a kid who's, pretty normal, didn't get, this kid didn't have encephalitis. How can this be? That, to me, is a big tip-off for PANDAS. When you see the kid who has 5 diagnoses, it's probably PANDAS. It's a pervasive disorder, PANDAS, okay? Just like we hear that word. What does that word pervasive means? All throughout, right? That's what pervasive developmental disorder means, is that it affects all fields of development. That's what autism is. So is PANDAS. It can affect all fields of development. And that's why I think the two may be related. It's a pervasive behavioral disorder, basically, instead of a developmental disorder. And so, that's one of the things. Taking that out of the symptoms was a problem. So we started this thing, a database, basically, when we first started, and this is now 2,007 patients. I'm just going to talk real quick about the LabCorp database, 674 patients in that, patients that had their tests. When we actually do, when you have enough numbers, you can look at a distribution curve. This has been done 3 times now in different data sets, and you get essentially overlapping curves. There is an infantile group, a group that is under 4 that presents with this. I don't know if they're the most severe, but they're a distinct group in the way they present from other kids. The main group is the Suedo syndrome, which has its peak at about age 8. And these numbers are when they come to me, so when I draw the blood. So this may be going, in some cases we've got to refine this and see when the actual age of onset was. So this is just an age distribution, but it gives you a rough idea of where things are, assuming that the delay to diagnosis is roughly similar. That's not necessarily a good assumption, so it's got to be checked, but it's probably correct. There's also an adolescent peak for sure in here. If you try to do a peak fit on this, like some people, in chemistry, we try to fit, chromatograms to the number of peaks there. There's another peak in the adolescent range too, and there may be a little blip in the adult range as well, but we can't tell. So in fact, I think this disease has different presentations in different age groups. There's an early infantile syndrome that, if it were present that young, would be indistinguishable from autism. So I think in the autism definition, there are even Kanner autism, possibly the classic degenerate, regression of skills between age 1 and 2. There may be kids that have PANDAS in there. There's this infantile mania syndrome that I was talking about, mimics mania, severe ADHD. You hear a 2-year-old kid that's bipolar, and that diagnosis comes up. I don't know if any of you have had that diagnosis made in a bipolar kid at age 2. And because depression and bipolar is so common, they're always going to find somebody in the family tree that has bipolar, and that's a diagnosis. So, but that's not the diagnosis. So, many of these kids, however, when you follow them over time, and now I don't follow them over time this way and wait, but in the past I have, they end up, I think, with PDD and OS. This is the group especially that has the very atypical response to stimulants and SSRI. If I were voting now for the criteria for PANDAS, I'd put an atypical response to stimulants and SSRI on the PANDAS criteria itself. So I think that's how common it is. It's not a diagnostic criteria, but it supports the diagnosis. That would help doctors to stay away from it. Just like, there's a condition called Lewy body encephalitis. All the doctors know there's an atypical response to neuroleptics in those patients. They stay away from those drugs. So the most common one, you can see by the peaks here, the juvenile onset, the Suedo syndrome, what we just talked about before. The classic PANDAS, sudden onset of TS and OCD. It looks like Tourette's syndrome. We had to say, what does it look like? Tourette's, OCD, the package deal of the associated with that. Dr. Kovacevic, Dr. K, the other one of these doctors, letter docs, very famous. I know a lot of you have seen him or know him very well. He's a great guy. He described an adolescent onset syndrome with pure OCD and anxiety, starting out of the blue, usually in late junior high school or high school. This is a kid who's a great student, star athlete, and then boom, this hits pure OCD and anxiety. And I know some of you have kids with that. That's probably the same syndrome as well. Here's one that I was involved with. I had to give this a name because it doesn't have a name. The Leroy syndrome. These are those girls that were up in Leroy who I'm sure have PANDAS. Now we know from other information that we've done on them. Woke up one day with pure motor tics on one side, a blast. They didn't know one another. They were the nicest kids as could be. One or two had a divorce going on or some little thing, but nothing that would make you think. And I can tell you now, by the way, a little follow-up on that. I heard from someone that the doctor that was involved, now the pediatric neurologist that was on the other side that made diagnosis of conversion, now believes in PANDAS as seeing patients, which is great. Yeah. And all those kids got better, every single one of them. This snowballed into it must have been a slow news period because it was dominating the news. I had no idea, what was going on at this point. So it got too much, too fast, and, I had to see patients. So I rapidly ran out of that gig there, so whatever. But this looks like both of these two things readily confuse a conversion disorder. These are, a lot of them are girls. There's something happened to them, and then they developed OCD and these tics, and they look kind of silly. It doesn't look like regular tics, and Dr. Pond says that's a conversion disorder, so it's a conversion. So whatever. I mean, because the people that write, that's how it's done, by the way. Psychogenic illnesses are done by gurus. What the guru says is psychogenic, everybody says. That's how it's done. It's unbelievably. That's what I see. But I might be wrong about that. So this would be the thought you have in your mind is a star student athlete that falls off the face of the earth. Then we have this other entity, which I also labeled term, which you guys has become common word, exorcist syndrome. I think you all know what this is. This is really scary. These are acute PANDAS crises. This is the seizure of PANDAS, if you will. These are sudden episodes where a child develops out of nowhere this severe rage response, these flailing arms, change in voice. It looks like a different person's in the body, and then shuts off like that. It's like a flushing, I'm sorry, Mommy. They may have some recollection, not always a recollection of what they did. I thought for sure I saw this for the first time around 2000. I don't know what the hell it was. And how could I be in neurology all this time and not see this? I'm just seeing different patients. These are not patients that would come to neurologists necessarily with these symptoms. They come to psychiatrists. A lot of parents wouldn't believe it. You have to videotape these kids to show. Because they're seizures. You can't go, when you go to a doctor and tell them I had a seizure, do it on history. There are many, many people with seizures. I've never seen their seizure because they happen once every 6 months or something, So the same here. You have to, that's why today, document, show the doctor, this is what I'm seeing. This is what I'm living with, so, you got to help me here, anyway. So let's talk a little bit about the mechanism of this disease. And I believe really there are two complementary theories, and it makes total sense if you think about it. One is molecular mimicry. I said them and us, but I don't mean that in a bad way. I believe in molecular mimicry. The molecular mimicry model works, and it's part of the problem. You think here's the thing. PANDAS is an interaction between your immune system and your brain, okay? Both, if you have to think about it, these are the two most complex parts of your body. The liver is complicated, but nowhere near as complicated as the immune system or the brain. So we're asking you, doctors, to try to understand the interaction between the two most complicated or sophisticated networks in our body, the immune system and the brain, both of which I would say are fractally complicated. You look deeper and deeper, and it's just as complicated as it was when you started. So it never gets easier as you get down to the molecular level. It just gets more of a tangled maze. It's just phenomenally incredible how the whole thing happens. Now, how do these two things interact? That's what PANDAS is all about, and all what neuroimmune disease is all about, too. So there are two compete. So basically, what's the immune system in a nutshell? It's got two basic parts. One that's called the innate immune system, and the other one is called the adaptive immune system. The innate immune system is what you were born with. It's innate. When you were born, you came out of your mommy's womb sterile. You never saw an organism. You should have never been exposed to infection in the womb or at birth. So your immune system has no idea what's out in the world. But that's a bad thing, because you're just a piece of meat as far as the bacteria are concerned. So just like a piece of meat laying on at 38 degrees, sitting on your shelf, come back the next day, it's going to be full of flies and stuff, right? So, so you have an innate immune system. Part of it is that your mommy was nice enough to give you a big dose of IVIG through her placenta, as maternal antibodies, which lasts a six-month dose of IVIG. It lasts pretty well. So that's very helpful. But you have this other thing, and unbelievably, like people never. What I just told you that makes sense. That it was only discovered through fruit fly genetics, actually, about 20 years ago. The innate immune system. When I went to I never heard of this stuff. Toll-like receptors. What the heck? I opened the book. I said, "What the hell is that? Is that like something to do with chocolate chips or something?" I had no ideas. So had no idea what it was. So that teaches you a lesson. If you want to read immunology, go to Amazon and always get the latest book. I don't care if it's who wrote the book, but don't get last year's book. It's already out of date. So this stuff really moves, So molecular mimicry and the alternative fever response. So the innate immune system has a lot to do, is basically the system that we have built into ourselves. And this includes such things as complement, cytokines, etc. Everything but antibodies. The adaptive immune system is antibodies, right? It's a smart immune system. It knows how to, or it involves T cells that know how, that have memory, have seen things before, can make a stronger immune response the second time. So you could immediately see vaccines. That's the adaptive immune system. That's why people theoretically don't give. And the innate immune system is really important when you're young. It stays kind of important. And then it seems the adaptive immune system kind of takes control. However, we now know that the innate immune system actually controls the adaptive immune system. It's the first barrier that organisms see is actually the innate immune system, and it actually talks to the fancier, more sophisticated adaptive immune system too. So both of these two things, the whole thing, are interacting. So the adaptive immune system is the antibody part, the autoantibody part, and the innate immune system is other things. And those other things are these molecules that lymphocytes use to talk to one another, called cytokines and other molecules. But that's, so if you think of the immune system as a defense system, police cars driving around the highway of your circulatory system, looking for trouble, looking for people to pull over. What's happening here? The cytokines would be like the communication system. So cops call for backup, need to bring in certain cells of a certain type to fight a certain infection. That's what they're there for. Molecular mimicry, we won't talk about it. Spend just a second on it, just mentioning that it's a complicated. This is the cartoon of the strep bacteria showing the highlights of some important antigens, and as that Madeline Cunningham told you a lot about yesterday, that antibodies are made to, especially M protein, but other proteins as well, on the strep surface. And those then, because they look alike or share some antigenic epitope complementarity to your own body, you get a cross-reactivity. And that idea's been around for a long time. And outside the brain, it's simple. You see that. You can look at the tissues. People die of rheumatic fever. You look at their hearts. There are the antibodies. So it's pretty straightforward. I mean, that idea is well established, that there is antibody deposition, and you can block out those antibodies with strep. So that's pretty well worked out. This is not really even this is like evolution. It's not really a theory anymore. It's there, molecular mimicry. So it's not the problem. Of course, is the brain, as Dr. Cunningham, of course, and her famous chart, which everybody puts in their talks. So this is the basic idea that everybody steals, but. The basic, this is the basic idea: genetically susceptible hosts, initial infectious trigger, abnormal immune response, you develop antibodies. Here are the problems with it. It's not just strep. Other bacteria, viruses, if this was the only thing going on, I'm not saying it doesn't happen, but if this was all that was happening, it would be hard to explain how other bacteria, viruses, and even non-infectious processes, that's probably true, and it triggers lead to a whole, and you get the phenotypes from any one of these things look the same. You can't tell if a child had Coxsackie B or strep or mycoplasma. They can have the same type of symptoms. They overlap. So that's a lot of mimicry going on, and all these different things. So there could be some things that overlap, and probably Coxsackie B and strep are one of them. But it's hard to understand how all of those things could give you the exactly same. I think that was the only thing going on. How do those huge antibodies get across the blood-brain barrier? It's like an ocean liner. If, glucose can't get across the blood-brain barrier. It's a tugboat. And this ocean liner now is trying to get across the Great Wall of China. It's very hard. So there has to be a mechanism. However, you just heard from this, how Driton and Kyle Williams, Driton's talk about how that's possible. There are mechanisms to do that. And there are at least several mechanisms that do that. And it happens in the brain. And he showed, at least in a rat model, that it happens. And I know he's trying to to extend his observations to humans as well. Why do symptoms have that lightning? How does that happen? They wake up. You started with a normal kid, and now you have a disease. Do antibodies fly into the brain that quickly? Is that? I guess they could. It's possible, but they'd have to be preformed, and then there'd have to be a sudden, rapid opening of the blood-brain barrier for some reason while your kid's sleeping, and this happens. Really, antibody-mediated disease doesn't happen that fast. There's only one that I can think of while I'm sitting here. It's anaphylaxis. But it's an antibody IgE-mediated disease. I could give you something that you're anaphylactic to. You won't make it to the door without feeling symptoms, So that'll happen fast. Why do symptoms? So that's a mystery. And many of our patients on the Cunningham test are seronegative, and there may be other explanations for that too. So we kind of wonder if there's something else going on. It doesn't mean that antibody-mediated process and possibly molecular mimetic process is not important, but there may be other pathogenic disease as well. The lowdown is this disease evolves. It starts off as something, and as time goes on, other mechanisms come into play. And you heard one clue of that is Driton's mentioning 17 strep infections, and then that process gets going. So the first young big kids that haven't had many, the disease is one thing. And then as the process goes on and on, especially untreated, you get something else. That may be why some of your kids, unfortunately, that weren't diagnosed for 4 or 5 years, might have a much harder disease to deal with. Here's Osler again. Chorea minor. Indeed, as far as I've had the opportunity of judging, the constant rule appears to be that chorea is aggravated in the initial stage of the fever. That is the cold stage, which we call the incubation period now, or stage of irritation, suspended more or less completely when the stage of reaction or hot stage is established. How many of your kids have had a fever and have gotten better during the fever? Maybe Osler wasn't right. I don't know. Anyway, so that's how many of your kids have never had a fever? That's even a better question. Now, so a lot more of those, yeah. So, yeah. A lot of these kids or infrequently get fevers. We got a lot more numbers online, maybe because people like me, I don't know. But the idea that Hippocrates also had this maxim, febris acid insolvus spasmo. Fevers come and the spasms, or in his case, chorea also loosens. So there's an inverse relationship between the two. So this is like our PANDAS database with all these patients, 2007 patients. ASO titers. By looking at a lot of patients, you can then measure things, get distribution curves, and you can easily see by doing a histogram there's a low ASO group. It's not normally distributed. The curve on the bottom is something called a quantile curve to tell if something is a normal distribution. That curve in a normal distribution should be a straight line, and you can see it's anything but a straight line. It curves. It's bimodal distribution. There are kids that have very low ASO responses in there too. It's never been commented on. It's just all you got to do is get the data and look at it. Okay. Now, how many of our kids are ASO positive? Now this is in that subset. We did ASO on some kids multiple times, so that wouldn't necessarily be fair, and we have to weed that out to do it properly. But just to get a ballpark number, 52% of our kids this is LabCorp criteria. So LabCorp says it's high. It says high. This clinician circles it, and the paper. It's high. So it's high in half of our kids, according to this. That's what the data suggests. Mycoplasma. IgG antibodies are present in about 3/4. But that's pretty common. Mycoplasma is a common infection. However, the IgM, which is not common, it's only seen for a brief period of time around infection, is seen in approximately 12%. Coxsackie B, which is a measurement of acute antibody because its complement-fixing antibody doesn't exist. Titers greater than 32 in about a third of patients. And there isn't, it's serotype specific, with B5 being the most important one when we include all of the data. So it's not across the board. Lyme turns out to be a minor player in this, but this is LabCorp, okay, folks? So I know that Lyme people out there know all about that. So just think, that's what you'll get from LabCorp from Lyme, that about 6% of our kids are going to be Lyme positive. But, that's definitely, I would say, definitely an underestimation. So these are just ballpark ideas. So what are, if you had to say, like, what's the list of pathogens that can cause this? Strep comes out to be the top. I have a feeling pneumococcus is as well, but I can't prove it. This is hard. But I'm trying to follow pneumococcal titers on patients and that exacerbate, and you can find that as a major cause. But certainly sinusitis is thought to be a major role. Mycoplasma, Lyme, and Coxsackie. About 13% of kids we never find anything on our workup. The combination of group A strep and Coxsackie can be particularly bad, though, however. Now, infection trigger versus host. There's a reason I picked these two teams, folks. Now, the host is, only the guys in the audience know who they are, right? Maybe I'm wrong. 6 minutes. 6-minute warning, okay. That's a football. Abnormalities in humoral immunity in PANS, total IgG levels. Okay, so let's look at the host side now. 25% of kids with PANS, this is now 757 patients, have one or more abnormal immunoglobulin levels if you exclude IgE, which has got a lot of variability. About 10% are hypogammaglobulinic, which means they have low IgG, and 12% are low in IgA, and 0.4% are absent in IgA. That's pretty common, though. IgA deficiencies, that's about right with the general population. There's this weird group that comes out, too. About 1 in 30 patients show a highly elevated IgA and a low IgM with a ratio of greater than 10, only boys. That's like there's an immunodeficiency syndrome that does that, too. That's called Wiskott-Aldrich syndrome. If any people have ever heard of that. It's a rare disease. But it's also thought to be rare. But I think there's a subgroup of kids that we can pick out from the data that have something like that. That already gives us a clue. 5% of our kids meet criteria for CVID. Okay, so that's important for IVIG purposes. Okay, that's about 1 in 20. All right, so those, at least 1 in 20 of our kids, just based on. I'm sorry. Common variable immunodeficiency disease, which just means that your antibodies of all types, it's a wastebasket term, and it includes a lot of different types. It includes low IgG, but also IgA, Ig subclasses, and unfortunately, you have to demonstrate a low response to pneumococcal antigens. So if that comes out low, to prove it, you have to give a kid pneumovax theoretically. So that's sometimes a problem with that. But that's our little loophole sometimes for getting a kid to get IVIG around insurance. They don't usually fight that. Another thing here is there's IgE abnormalities in PANS. There's a low IgE subgroup and a rarer hyper IgE subgroup, which looks like it's very different and not related to allergies. It may be related as a spectrum of something called hyper IgE syndrome. But most of the patients have low IgE. There's subclass deficiency in PANS, which are comparable to those seen in primary immunodeficiency. So, for example, we see IgG4 subclass deficiency in 17% of kids with PANDAS, whereas even in the primary immunodeficiency group, 9%, and only 1% in healthy population. Those two actually go together, the IgE and IgG4 deficiency groups. They parallel one another, and if you would actually plot them out side by side on the next slide, they correlate extremely strongly. Doesn't look like they correlate, but you can sort of see that that's where the line goes, and there's a lot of points there, so that's a highly, highly significant correlation coefficient. So IgGE and POR correlate. They go down and up together. I've also done cytokine measurements. It turns out that IL-4 and what makes IgG4 and IgE go low? There's certain cytokines that do that, class switching, and they're very low in patients with PANDAS. IL-4 and IL-13 is down. Those are the Th2 cytokines. IL-10 is also dysregulated in PANS. The other phenomenon too, which here, is their basophil level is always low in PANDAS. I've never seen it over 50. Unless the kid has a parasitic infection, it's always very low. So essentially puts the immune system in an anti-allergic or anti-anaphylactic state. This is what I think, that basically PANDAS exists because of the need to, the evolutionary selection pressure against anaphylaxis. If you're exposed to peanut allergy 500 years ago, you're dead. Your DNA is not going on to the next generation. So there's selection pressure from evolution against anaphylaxis, and that might be PANS, what PANS is all about. So that's the price you pay. Now, evolution is trading off a fatal illness for one that causes a lot of, kind of a pain in the butt, but not going to kill you. So it'll always make that choice every time. So what we see here is, by looking at the various pools, this is normal, this is PANDAS. There's a low histamine state. And in the low histamine state, there's also, I'm going to have to go a little bit faster here. This PANDAS-prone immunopenia, we can do blood tests to tell if your child has a state like this. And I would say probably a lot of patients have one or more of these criteria, and at least 80% do. So the idea of the alternative fever response is that PANDAS is a fever mechanism taking a wrong turn. The locus of action is in the hypothalamus. When the normal immunophenotype encounters triggers, you get fever. And when the PANDAS-prone immunophenotype encounters triggers, you get PANS as a result. So it's all a matter of the host. And let's get to genes. Okay. We've done microarray. This is just interesting. We've done microarrays in patients with PANDAS. So I don't know if you know what they are. They're looking for deletions of genes. 36% have abnormal microarrays. It's a phenomenally high number, much higher than we thought. About 60% of those have PDD PANS. It's a very high number. If you do those studies in autism, they're around 10 to 20%. 10% of the positive microarrays that we did, of something like 200 patients, all go to, 10% of them go to the non-imprinted Prader-Willi region in 15q, which is very interesting because Prader-Willi is a well-known biological cause of OCD. I mean, that's one of the things they have as part, hallmark of that syndrome is compulsive eating. So it's very interesting that we have genes right around that. They're non-imprinted, though, outside of the region. I won't even be able to tell you what imprinting is, but that's okay. Mitochondria and PANS. This is the coordination testing we do on your patients, which I can explain. I have about 20 seconds to explain it to you, but these are the genes that pop up. What we do is we do coordination testing on lots of kids, and then look based on, and we know the something called 1,000 genomes frequency of how often certain mutations are supposed to be there. Certain genes are enriched in PANS. The ones that are popping up, interestingly, are all a class of proteins called peroxyredoxins, which I'd never heard of before until I did this, and they turn out to be genes that are very important in free radical formation. And this is the family here, oxidized peroxyredoxins, etc. If this observation is correct, this association is correct, and it means something, we got to do a lot more experiments to prove this. That's a very important thing in the immune system, and it also points a way out of the problem, how to boost your immune system by treating naturopathically in ways to suck up the free radicals that would be generated here. Now, I know there's Dr. Meyerhoff in the audience, a nitric oxide specialist. When you see a problem with hydrogen peroxide production, you immediately think nitric oxide, peroxynitrite, and a lot of problems. So when you have an impaired disposal, when you have too much brain, iron, that's what happens. Anyway, I feel the cane across my neck here. Okay. All right. Thanks very much. Let me just summarize real quickly here. PANS is a common disorder, wide range of manifestations, acute OCD, tics, and other symptoms. I think there's at least 4 clinical subsyndromes. There's a remarkable response to prostaglandin inhibitors and ibuprofen in many patients, maybe not all. Many different triggers. Mechanism, I think, early on is largely an alternative fever response. There definitely molecular mechanism with some triggers. As time goes on, those autoantibodies become more and more important. And there's disimmunity, immunodeficiency, and eventually autoimmunity. And I didn't have time for this, but peripheral and central histaminergic mechanisms are important, and several genes are implicated. Thank you very much.